Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Hello, everyone, and welcome. I'm going to talk about using or different approaches for the treatment of inadequate response to major depression with a focus closer to the end on brexpiprazole. This is my presenter disclosure. So what is treatment-resistant depression? And really, there is no universally accepted definition. We know there's a number of different ways that people define this based on potentially minimum dosing or duration of a treatment, the kind of complexity of treatment they've already had, perhaps lack of response to ECT. So just flashing up here quickly, all of the different or several different models for TRD. The one that is most often referred to is the concept of a failure to achieve remission with 2 or more adequate antidepressant trials. That is a very simplified view because there is no accepted definition. The question is, have you squeezed everything out of the current treatment? Is 100 milligrams the optimization of the desvenlafaxine? I want to remind everyone that while we tend to have groups of antidepressants, SSRIs, SNRIs, multimodal agents, that each one in every category is a unique chemical entity. So we can have people who fail a couple of SSRIs and then respond to one because that is the drug that's right for them. And if you look at the CANMET guidelines for antidepressants, with the first line, which is level 1 or level 2 evidence with clinical experience, second line, which is maybe that there are some side effects, still an efficacious medication may have level 1 or level 2 evidence, but maybe not as much clinical experience or some side effects, or maybe the level of data is not as strong. And then third line medications. Arguably, MAOIs, very effective antidepressants, but come with some burden. So when you take all those together, there are 25 different antidepressants here. So you've got to try to pick the right one for your patient based on what they'll tolerate, what's worked before. The dosing, and that's the point of this particular section, is what dose do you choose? How far do you go with the medication? And just reminding everyone, the product monograph dosing guides come from the drug company. They do dose finding studies and they make the recommendations, and then the regulatory body determines if that's appropriate. There are very few medications that we use in psychiatry that have a narrow therapeutic index. In fact, that's lithium. So we don't run amok and go crazy with the doses of lithium because of the fact that if you go outside the dose range, you can have some very serious outcomes. Otherwise, the recommendation that I follow, or the path that I follow, is ultimately the dose is determined by efficacy and tolerability. I start low, I go slow, and I aim for full symptom resolution. If I'm at 150 milligrams of desvenlafaxine and I find that there's some improvement, 20% or more improvement in symptoms, I'm likely to go to 150 milligrams and so on. Venlafaxine XR is a good example of how we sometimes hyperdose medications because the upper end of the dose range in Canada is 225 milligrams. But when I was using that drug frequently, I was using 300, 375, 450 every day. The most common reasons, of course, they don't like the side effects. They feel they don't need medication. Maybe they're feeling better, although it's quite a bit too early to stop the medication. And so some important education to go on there. And what are the most common side effects? Sexual dysfunction or complaints, sexual dysfunction, weight gain. Anxiety is highlighted here, but I often find that when I'm treating someone for depression and their depressed mood starts to get better, they really start to notice the prominent anxiety symptoms. And so they sometimes are concerned that the antidepressant is worsening their anxiety instead of it becoming potentially more apparent to them. Are new drugs better? Some of the new treatments better? For patients, sometimes, yes, we know that all medications, all antidepressants work, but there are some that are better than others for individual patients. So globally, we can't say that the new drugs, the new antidepressants work better, but for individual patients, one may work better than another. And what the real benefit is of newer medications, often the side effects are more tolerable. For payers, usually no. Usually they will say that they do not wish to cover newer medications. Payers don't understand the power of neuroprogression, the fact that we should be treating early and fully, and the impact of functional impairment. Now, we know that the major risk, as I just said, for compliance is due to side effects, but also due to cost and clinician comfort, what they're used to using. And that's why it's so important for us to gather together in these kind of meetings and share experiences in using different treatments. The half-lives, quite close, at least 2 weeks for aripiprazole, closer to 3 weeks for brexpiprazole, so it takes a little longer to titrate. But one of the great benefits with brexpiprazole versus aripiprazole is the dose range. So aripiprazole, when I see a patient, I usually start at 1 milligram, depending on how much time I have and how ill they are. And I can end up somewhere between 1 and 30 milligrams, depending on the illness. Where with brexpiprazole, we're between 0.5 and 4. So it takes, I take a little more time with the dose change, but I find it easier to get to the right dose. And for depression, usually in the 1 to 2 milligram range, which I can reach more quickly. I tend to, with aripiprazole, take a lot longer. And finally, my point number 7, be kind. So I hope I made the point right from the beginning that we have to treat everyone we see as an individual. We have to treat compassionately. We have to treat early. We have to treat fully. That reduces suffering and long-term harm, both for brain functioning. So we preserve someone's cognitive capacity, but also it increases the likelihood of full functional recovery, getting them back to work, back to life, back to love. Be kind. Thank you very much.
Hi, my name is Lakshmi Yatham. I'm head of the Department of Psychiatry at UBC in Vancouver. I've been asked to present on broad spectrum efficacy of cariprazine in the management of bipolar disorder. So here are the 3 things that I'm hoping to cover in the next 15 minutes. First, we'll talk very briefly about the pharmacology of cariprazine. Then we'll examine the evidence for efficacy of cariprazine in treating acute mania and also acute bipolar depression. And as I do that, I'll also present some data which demonstrates broader spectrum efficacy of cariprazine based on some of the post hoc analyses that we've done from the mania and bipolar depression randomized controlled trials. So they were all multi-center randomized double-blind placebo-controlled trials. In the first 2 studies, cariprazine 3 to 12 milligrams flexible dose was compared with placebo. And in the 3rd study, there were 2 fixed flexible doses, meaning that one group was allowed to get between 3 to 6 milligrams of cariprazine daily, and the other group was allowed to get 6 to 12 milligrams of cariprazine daily, and these 2 doses were compared with placebo. In all 3 studies, the duration of the double-blind phase was about 3 weeks, with a 1-week screen washout period and 2 weeks of follow-up phase as well. And the eligibility criteria for these mania studies were very similar to all the previous mania studies that have been done with other compounds. So patients aged 18 to 65, meeting criteria for a manic or a mixed episode based on the DSM-4 TR, with a YMRS total score of 20 or higher. And patients also needed to have 4 or more on 2 of the YMRS items, such as irritability, speech, content, or disruptive aggressive behavior. Patients experiencing their first manic episode and those that had significant suicide risk were excluded from these studies. This slide shows you the response rates based on 50% or greater improvement on YMRS scores in each of the studies, and also the pooled response rates. And as you can see, the response rates for the cariprazine group ranged from 48 to 61%. And if you look at the pooled data, the mean response rate is about 57% for cariprazine and 36% for placebo, about 20% difference, which translates to about number needed to treat of 5, which is excellent. Remission rates are a little bit lower than response rates, which you might expect, because remission is defined a bit more stringently as a score of 12 or less on YMRS. And again, this slide shows you the remission rates in each of the studies for cariprazine versus placebo, and also the pooled remission rates. And again, as you can see, there's about a 16% advantage in remission rates for the cariprazine versus placebo, which translates to an NNT of 7, which also, again, is excellent. And they recruited bipolar 1 depressed patients scoring 20 or more on Hamilton Depression's rating scale. And the primary efficacy measure was the change in the MADRS rating scale score from baseline to week 6. And this shows you the demographic characteristics for all 3 studies. And again, the mean age in these studies was about 40 approximately across the studies, which is typical in bipolar depression trials. Now, unlike in mania studies, more women participate in bipolar depression studies, so 60 versus 40 in mania studies, and that's again very typical. BMI was slightly greater in the bipolar depression trials compared with the mania studies, and the MADRS mean score is about 30, which is typical of what we see in bipolar depression trials. So with that, let me summarize then what I've said so far. We talked about its pharmacological profile, suggesting that it has a preferential affinity for D3, although it does have affinity for D2 as well. And it has antagonistic effects on the other 5-HT2 types of receptors. One unique characteristic of cariprazine is that it does have a long half-life, particularly for its metabolite, which has a half-life of up to 3 weeks. And clearly, there's evidence for efficacy of cariprazine in acute mania and acute bipolar depression, each supported by 3 double-blind RCTs. And based on these RCTs, FDA has approved this for both these indications. And many post-hoc analyses that I've done from these studies seem to suggest that cariprazine is effective across a wide range of bipolar patient populations with the differing clinical and demographic characteristics. And finally, maintenance study has been ongoing for some time, and there have been some delays with COVID, but the results are expected in about a year or so, and hopefully that would provide the full spectrum of its efficacy for all phases of bipolar disorder. So I'm going to stop there. Thank you very much for your attention.